Go. Welcome, everybody. Welcome, welcome. Give another minute or so for anyone just joining us in this virtual space today to work out their audio or get logged in. And I'll get started in just a moment. There we go. Okay, so I would like to welcome everyone to the Workplace Violence Prevention and De-escalation in Healthcare webinar. This webinar is hosted and presented by British Columbia Dental Hygienists Association and the Nurses and Nurse Practitioners of BC, with content and presentation by the Public Services Health and Safety Association. Thank you all for joining and taking time of your busy day to sit with us, to learn more, and to engage in this very important topic. As this is been designed to support and focus on nurses, nurse practitioners, and dental hygienists in BC. Before we start, I'd like to acknowledge with deep respect that I'm calling in from the traditional and unceded homelands of the Syilx Okanagan people, what is colonially known as Penticton. I'd also like to acknowledge that we are all joining today from a variety of homelands and that NMPBC and BCDHA, we work on support nurses and dental hygienists doing their work across the entirety of the province, which Indigenous peoples have stewarded since time immemorial. This is the homeland for more than 200 First Nations, chartered Métis communities, and visiting and sheltered Inuit. Today, we spent some time getting to know one another. I'll invite you to reflect on the lands that you're calling in from. This webinar will explore factors that contribute to workplace violence, practical de-escalation techniques, personal safety considerations, organizational responsibilities, and reporting requirements, as well as post-incident response strategies, including reporting, recovering, and available supports and resources. This session is grounded in BC and occupational health and safety requirements, trauma-informed and culturally safe practices, and is designed to support nurses, NPs, and dental hygienists in BC, building confidence and readiness to prevent, respond to, and recover from workplace violence. This webinar will include interactive polling and a moderated Q&A at the end. Recording of this session is already happening, and it will be posted online after for those who were not able to attend the live event. The Q&A at the end will be part of this session, and some of the panelists and webinar hosts include Elena Payne, Director of Practice Excellence, Knowledge and Policy at NMPBC, myself, Nicole Dore, Manager of Practice Education and Research at NMPBC, and Shannon Wilson, Practice Education and Manager for the BC Dental Hygienists Association, as well as our guest speaker and presenter today, Elena Chapovlov, a health and safety consultant with the Public Services Health and Safety Association, who is a registered nurse with nearly 20 years of experience in preventing workplace harm, promoting employee well-being, and she holds a master's in public health, BSc in psychology, BSc in nursing, and a graduate diploma in health services and policy research. Elena has a designation of this Canadian Registered Safety Professional. Elena's clinical research and background spans complex and continuing care, long-term care, and Canada's largest mental health and addictions teaching hospital, where she has translated research into practical safety initiatives for public service workers. Elena has completed 2 secondments with the Ontario Ministry of Labour, Immigration, Training and Skills Development with a focus on workplace violence prevention, where she's facilitated working groups with members from across the system. So without further ado, I'd like to welcome Elena and hand over the mic to you. We're very excited to get an overview on this very important topic. Thank you so much.
Excellent. Thank you, Nicole. And hello, everyone. Thank you for allowing me to be part of this important initiative. I'm really excited to share the information and to start raising awareness about what can we do as a system, as individuals to support each other. So just going to share my screen here so everyone can see and follow along. Okay, just checking to see that everyone is able to see the slides. Excellent. Okay. So now we'll move on into the main presentation on workplace violence in healthcare and de-escalation. In this section, we'll look at understanding the issue through recognizing risk and escalation and into practical prevention and response strategies. So my focus is taking all that body of knowledge and making sense of it, making sure that we understand what it means in our day-to-day practice. Here's our agenda for today. We'll begin with understanding workplace violence in healthcare in BC, British Columbia. From there, we'll discuss contributors to violence and escalation, the principles of de-escalation, and the role of nurses, nurse practitioners, and dental hygienists during high-risk situations. We'll then look at organizational responsibilities, shared accountability, followed by our look at recovery and reporting after an incident. And we'll close with some key takeaways and our Q&A. As we begin, I want to ground the session in a few key principles. First, violence is not part of the job. The phrase is simple, but it matters. Too often, healthcare workers are expected to absorb aggression, threats, intimidation, as though they're inevitable occupational experiences. These are not acceptable and should not be normalized in our healthcare settings. Second, I want to highlight the conversation is going to focus on prevention. It is about improving the working lives of workers in British Columbia by identifying risks early, strengthening responses, and building safer systems for everyone. Third, when incidents do happen, what we do after as a post-incident response matters. Reporting, support, follow-up are not optional extras. They are essential parts of safety, healing, and organizational learning. Workplace violence in BC healthcare has to be understood in context. Healthcare workers, nurses, nurse practitioners, dental hygienists practice in very diverse settings. Community, acute care, long-term care, dental clinics, outreach, corrections, and many more. The risks, triggers, and available supports can look very different across those settings. There's also a clear legal and regulatory framework in BC, including the Workers' Compensation Act, the Occupational Health Safety Regulation, and oversight from WorkSafe BC. Finally, the client and patient context matters. Workers may be caring for people experiencing pain, fear, trauma, cognitive impairment, mental health concerns, substance-related impairment, or the effects of broader social and system pressures. None of that, of course, excuses violence, but it does help us understand the conditions in which risk may emerge and how prevention may be tailored. Workplace violence has consequences at every level. For individuals, it can lead to physical injury, stress, burnout, anxiety, loss of confidence, and time away from work. For teams and organizations, it can contribute to decreased productivity, higher absenteeism rates, lower morale, and higher turnover. When we look at the system level, the health system level, it can even contribute to the loss of nurses, hygienists, nurse practitioners from the profession. Importantly, when the healthcare workers are threatened, intimidated, or harmed, it can undermine their ability to provide safe and effective patient care. So there's a strong connection to providing excellent care when our staff are safe. So overall, this is not only a worker safety issue, it's also a care quality, staffing, and health system issue. It is important to define workplace violence broadly. Using the WorkSafe BC approach, workplace violence can include physical assault, attempted assault, threats, intimidating behavior, and also harassment, bullying, and verbal aggression. The broader definition matters because people sometimes think workplace violence refers only to physical attacks. In reality, many harmful incidents begin earlier with verbal aggression, intimidation, or repeated disrespect. It's also important to make the connection explicit. Harassment that's tolerated or left unresolved in the workplace can escalate to workplace violence. So that means early recognition and response are critical. There are different forms or types of workplace violence that we have categorized. It's important to distinguish them because it will help with planning or prevention initiatives. The four types are here. Type 1 involves violence from members of the public or people with no legitimate relationship to the workplace. Type 2 involves violence from patients, residents, or clients, which is often the category most discussed in healthcare. This is where we see most of our incidents of violence fall under Type 2. Type 3 is worker-to-worker violence, including bullying, harassment, intimidation, aggression that happens between colleagues. Type 4 violence is the domestic or intimate partner violence that enters the workplace context. So all four matter in healthcare, and we usually ask the employers, to set up reporting systems that identify the source of violence. And this will help with prevention strategies because the controls or preventative measures will differ for each of the levels, different types. The BC Occupational Health and Safety Regulation sets out key responsibilities related to workplace violence. Employers are expected to conduct a risk assessment that will identify circumstances in which workers may be exposed to violence. They must also establish procedures to eliminate or minimize risks, providing appropriate worker training, ensuring that there are clear incident reporting processes and investigations. Workers also have a right to refuse unsafe work under certain circumstances, and that right is an important part of the overall safety framework. The regulation reinforces that prevention is not optional. It is a legal and organizational requirement and a responsibility. On this slide, we see the highlights of the broader provincial level data from WorkSafe BC. And the purpose is to situate workplace violence within a larger occupational health and safety picture and to emphasize that this is a documented and ongoing issue and not an isolated concern. When we look at compensation and injury data, we see that healthcare continues to be a sector with significant exposure to injuries of all claim types. With the surveillance data, the numbers are important. It is a lagging indicator. We're looking at things that have already happened, that even with attempting to prevent, the claims have been allowed, the injuries have happened, but they still are important for us to understand the extent of the issue. And also important to keep in mind that there's still some underreporting that may be happening with these numbers. This figure here helps to illustrate the burden on workplace violence, injury claims, and lost work time across subsectors. For the discussion, what really matters is not only the number of incidences, but also the impact those incidents have overall in terms of time lost. So time lost meaning the workers sustained an injury that was significant enough, severe enough for them to be off work, losing time from work. in terms of the impact on recovery, staffing disruption, and the ongoing effects on workers and teams. Data like this really help make visible the operational and human costs of violence in the workplace. With this slide, it's pointing um, to, uh, asking us to pause and reflect on what may sit behind the numbers. The one important issue is the relationship between bullying, harassment, and workplace violence more broadly. Harm does not always begin with physical aggression. In fact, it can begin with disrespect, repeated intimidation, exclusion, verbal abuse, or normalized hostility. If those behaviors are minimized or tolerated in the workplace, they can create a culture where more serious incidents become more likely. So when we talk about the violence prevention approaches, we should always be thinking about workplace culture, respectful communication, and early intervention. It's important to acknowledge the limitations of workplace violence data. There is, again, we know that there's significant underreporting happening. Some incidences are never, some incidents are never reported, documented because workers may feel reporting will not help, may have fear of stigma around reporting, may worry about professional consequences, or may even may have internalized that idea of violence as being part of the healthcare work. There can also be inaccurate or inconsistent reporting, especially when incidences are described differently across settings or when contributing factors are poorly captured. And that is why it's very important to have that consistent definition of workplace violence and breaking it down by types for reporting. Since the COVID-19 pandemic, there's evidence that workplace stressors and violence have intensified in many settings. So even when the data are useful, we really need to see this information. They may still be underestimating the current reality. And the Canadian Federation of Nurses Union, CFNU, data were collected before COVID. And there's now emerging evidence through research that workplace stress and violence have only intensified since then. There are several reasons workplace violence is a priority in BC healthcare right now. Patient conditions are often more complex. And many of you are experiencing this and seeing the change. Patients coming in with higher acuity, multiple comorbidities. Healthcare workers are also increasingly caring for people affected by mental health concerns, substance use, trauma, housing instability, and the broader social inequities. At the same time, staffing shortages, system strain can increase wait times, reduce that continuity, and limit opportunities for early intervention, all of which can collectively raise the risk for workplace violence. Taken together, these realities help explain why healthcare remains one of the higher risk sectors for workplace violence. Violence and escalation are rarely caused by just one factor. There are human factors such as cognitive impairment, delirium, dementia, mental health conditions, substance-related impairment. There could be pain, fear, frustration, or unmet needs. We also have potentially some environmental factors, organizational system factors that may include long wait times, overcrowding, lack of privacy, understaffing, poor communication, and workplace cultures that tolerate harassment or disrespect. This is important because it shifts us away from blaming individuals alone and toward understanding how risk develops within a broader context. Prevention is most effective when it addresses both immediate triggers and underlying conditions. Escalation often happens along a continuum. In the early stage, we may see agitation, pacing, repetitive questions, restlessness, or a raised tone. In the mid stage, behavior may become more threatening, verbal threats, clenched fists, invasion of personal space, or refusal to follow direction. In the late stage, the risk of physical aggression increases, including attempts to strike, grab, bite, or otherwise harm others in the workplace. And the key point here is that early recognition creates more opportunities for de-escalation. The earlier we notice change, the more options we usually have. Some of you may have seen this before, the hierarchy of controls. This reminds us that prevention should not rely only on individual workers managing dangerous situations in the moment. At the top of the hierarchy are more effective system level measures. So we always try to start at the hazard level, try to eliminate, substitute the hazard. And this applies to all occupational hazards, not just workplace violence. Then, if not possible, which with workplace violence, unfortunately, typically it's not possible to completely eliminate it from our workplaces, we rely on other measures along the continuum, along the path, engineering, administrative controls. So in healthcare, that might include safer workspace designs, putting in place alarm systems, staffing approaches, flagging or client risk identification and notification and communication of those risks to everyone involved. Workflow changes, policies, training, those are all examples of the engineering and administrative controls. PPE, personal protective equipment, has a role, but it's not the primary solution. We really encourage employers against going straight to PPE when they're exploring potential controls and preventative measures. We really need to look at others before we rely on the worker level controls. A strong workplace violence prevention approach focuses on building that safer system and not simply expecting workers to cope better. De-escalation starts with a set of foundational principles, and these include trauma-informed practice, cultural humility, respect for autonomy, collaboration rather than control, and maintaining both dignity and safety. This means we're not simply trying to make someone comply. We are trying to reduce threat, support regulation, and create conditions where communication can continue more safely. These principles are especially important in healthcare because people may be frightened, confused, in pain, overwhelmed, or carrying past trauma into the interactions. Effective de-escalation is often grounded in very practical communication choices. A calm, even tone can help reduce perceived threat. Simple instructions are often easier to process than long explanations, especially when we have a patient or a client who's distressed or cognitively overwhelmed. It is important to avoid power struggles. We can acknowledge feelings without agreeing with inappropriate behavior. For example, we might say, I can see that you are upset and I want to understand what are your needs, while still setting boundaries around safety. Giving the person space and time, using supportive nonverbal communication. And as care providers, we've all been trained in the importance of that nonverbal communication. So that can all be used to help reduce escalation. Some behaviors that appear aggressive may be better understood as responsive behaviors that may be linked to dementia, delirium, neurodivergence, trauma, or other unmet needs in our clients. That does not make the behavior harmless, but it does affect how we respond. We need to ask, what might this behavior be communicating? Is the person in pain, Are they confused, overstimulated, frightened, unable to understand what's happening? So where possible, environmental adjustments need to be made, reducing noise, improving orientation, slowing the interaction, changing approach, involving family support or something that, will provide some comfort. And this will help to reduce that distress more effectively than confrontation. In high-risk situations, the role of nurses and dental hygienists involves both clinical judgment and personal safety awareness. So you're managing those two big pieces, right? So there's a lot of juggling happening. Positioning matters, so maintaining an exit route where possible, avoiding cornering the patient or client, staying aware of the physical environment, that situational awareness, and any nearby hazards. Team coordination is critical, calling for support early rather than waiting for the situation to deteriorate. When possible, assigning clear roles. For example, you're going to have someone who's a lead communicator, observer, or a person that goes to get additional help, kind of like what we do in a first aid situation. At the same time, we need to balance care needs with staff safety. This is a challenge in healthcare. So good decision making includes assessing that urgency, identifying triggers, and considering safer alternatives. Documentation after a high risk event should be objective, factual, and timely. And of course, in being in healthcare, we all know the importance of documentation. If it's not documented, it did not happen. That means, describing the behavior observed, warning signs, any actions that were taken as a result, the outcome or follow-up needs without judgmental or inflammatory language. This slide here highlights the important point that there are times where the safest and most appropriate action is to withdraw and call for help. If the level of risk exceeds the likely benefit of continuing the interaction, workers should not feel obligated to push through at the expense of safety. The right to refuse unsafe work under some circumstances and the need for team support, continuity of care are both important considerations. Preventing workplace violence is not solely an individual responsibility. I know our focus here today is on the worker level administrative controls, but it is a team approach. So employers also have clear obligations to provide policies, procedures, training, PPE, personal protective equipment, and engineering controls where appropriate, and also conduct regular risk assessments around workplace violence. There must also be clear expectations for reporting, and this is workers' responsibility. They need to report threats, harassment, aggression, incidents, and employers need to investigate and act on that information. Documentation is not just administrative or legal requirement. It helps identify patterns, informs prevention priorities, and supports better training and system improvement. So we follow that PDCA, Plan, Do, Check, Act cycle with our workplace violence programs. Incident reporting only improves safety if organizations actually learn from it. Trends analysis will help identify repeated patterns such as common times, locations, triggers, staffing issues, or population-specific risks. That information should lead to organizational learning, reviewing of controls, and concrete changes to practice or environment. It is also very important to close the feedback loop by communicating outcomes to staff. And I do see this, I work with many clients, this not being done where workers report incidents, but they never hear back from what changed. And I know employers are doing things, but without communicating widely to everyone involved on the controls and preventative measures, confidence in the reporting process can erode. After an incident, the response should include both immediate and longer term elements. Diffusing is more of that immediate, brief emotional check-in after the event. It is focused on stabilization and support. Debriefing happens later and is more structured. It focuses on learning, support, and prevention. We also may need to have processes internally around medical follow-up. When we have a physical injury or exposure, such as blood and bodily fluids exposure, reporting should be timely, factual, and complete, including any internal reporting requirements and external reporting requirements, WorkSafe BC processes where applicable. When we talk about workplace violence, we also need to think beyond the initial incident. Secondary hazards can include psychological harm, such as anxiety, stress, hypervigilance. And in my practice as an occupational health and safety nurse prior to joining PSHSA, I have seen many times where practitioners absorb workplace violence. There's no reporting. They think this is part of the job. They continue to push through years of that exposure. And then that one incident really impacts them, right? And so that accumulative trauma is very real. This is something that we are now starting to realize and see in our workers. So reporting needs to be encouraged after every event. They can also include MSDs, musculoskeletal injuries, or musculoskeletal disorders from restraining, reacting suddenly, falling. We've seen critical injuries here in some of my areas with concussions, broken skull. So, right, so physical injuries when it comes to violence are very, very real as well. Biological exposures and other physical hazards such as slip, strips, and falls or damaged equipment. These are all part of the secondary hazards that we could see. Documenting these secondary harms is also important because it supports a more complete prevention and recovery response. Otherwise, the true impact of an incident may be missed. So now this brings us to our first activity here to apply the knowledge that you already have and maybe something new you learned today. So the scenario here is the patient begins pacing, raising their voice, and pointing toward the door, saying, I need to get out now. Think about the options here for the next safest step. And you want to take a little bit of a couple of seconds here to identify what is the next safest step here. Block the exit, match their tone to show authority, speak calmly, offer space, validate feelings, or ignore until they come down. All right, so let me
You should have
see.
a pop-up now come into polls and quizzes that you'll be able to engage with.
Okay, so let's see. We have any responses?
Yes, we do. It's still going.
Okay, perfect. Give you a little bit more time.
Okay, it slowed down. We have 96% for C.
Okay, yay! That's great. Okay, I can't see it, but I'm happy that that's what we got. That's what I was expecting. So the best response is C, speaking calmly, offering space, validating feelings. So nobody's blocking the exit, matching the person's tone, ignoring the situation. So because these would increase the risk. The scenario reflects an early to mid-stage escalation point where calm communication, space, emotional acknowledgement can really help to reduce that threat and preserve the feeling of safety. Alrighty, so we have our next one. A family member becomes verbally aggressive towards staff over wait times. Unfortunately, we've seen too many news around that lately across Canada with wait times in the emergency department that has increased. What is the most appropriate response here? So we have explained policy clearly to assert control, move to a private space, acknowledge frustration and explore needs, call security immediately, tell them they must leave. Okay, so we'll give you some time to select your best choice. Few more seconds.
We have 92% for B.
Perfect. Thank you, Beatrice. So the best answer is B. Yes. Moving to a private space, acknowledging frustration, exploring needs. If it is safe and feasible to do so, that's key. And of course, every situation is unique and requires that assessment for urgency. But this approach will help you to reduce that public tension, communicates respect, creates that opportunity to understand what's driving the distress. And we're healthcare providers, but many of us have been on the other side as a patient and receiver of care, right? So how would you expect to be treated when there's a concern with wait times, for example? Immediate security involvement or removal may be needed in some cases, so that's not wrong, but not as the default first step when de-escalation remains possible. And here, in closing, I want to reinforce a few key messages. Violence is never part of the job. Nurses, nurse practitioners, dental hygienists play an essential role in recognizing, assessing, reporting, controlling, and helping prevent workplace violence in their workplace. Workplace violence is preventable, and de-escalation depends on awareness, communication, and collaboration. Reporting and post-incident support are essential, not just for individual recovery, but also for system learning and prevention. And finally, creating that safer workplace is a shared responsibility. It requires action from individuals, teams, leaders, and organizations across healthcare settings in BC. This slide lists several helpful resources for further learning and practice support, including the WorkSafe BC resources, student violence prevention training materials, Switch BC, provincial violence prevention curriculum, violence risk screening resources, WorkSafe BC, claims data tools. So these resources collectively can support the deeper understanding, learning about the topic, workplace education, policy review, and local prevention planning. I do have some research around respectful workplaces, mental health impacts of workplace violence, evidence related to de-escalation intervention in healthcare settings. These references may be useful for anyone who wants to explore the evidence base further to support policy, education, quality improvement work in their own setting. And there's, of course, a lot more that's happening in this area of research. This is it. So I want to thank you for your time, for your attention and engagement today. This is a challenging topic, but it's also a critical one. Safer workplaces are possible, and we've seen it happen with commitment and time. These conversations need to be part of every organization, every team, because they really help to build that change. I think now